Hello everyone, this is the Panopto recording for musculoskeletal care and musculoskeletal disorders. A strain is a soft tissue injury that occurs when a muscle or tendon is excessively stretched. Strains can be classified as mild to severe. Mild would mean minimal inflammation or swelling and tenderness. Moderate is partial tearing of the muscle or tendon fibers with pain and associated and an inability to move the affected body part. And then severe is where the muscle or tendon becomes ruptured with separation from the muscle or tendon from muscle or the tendon from bone. And this leads to severe pain and disability. Sprains are excessive stretching of ligaments from twisting movements during a sports activity, exercise, or fall. Sprains are also classified as mild to severe. Mild is considered a tearing of a few ligament fibers that causes tenderness. Moderate is more ligament fibers are being torn with no loss of joint stability. And in severe cases, instability of the joint, and it usually requires a surgical repair of the tissue. Okay, the mnemonic, immediately after a strain, the injured area should be rested to protect it. Ice should be applied to decrease swelling, pain, and inflammation. Compression, if it's appropriate, as well as elevation to provide support to reduce the swelling. The mnemonic to remember for this would be RICE. NSAIDs can be given to reduce inflammation and swelling. You can also utilize muscle relaxants to help treat any pain related to muscle spasms. Exercise should be withheld for 2 to 5 days or up to 1 to 3 weeks depending on the severity of the injury. After the inflammation subsides, you can utilize heat application for 15 to 30 minutes about 4 times a day. This will help restore blood flow to the injured area and help with healing. But heat should not be used until after the inflammation has subsided. Okay. It's important as nurses that we are safe. Musculoskeletal injuries are common among healthcare professionals, so make sure that we are using lifting devices such as draw sheets or mechanical moving devices, and we should avoid pulling on the patient's arm to prevent any shearing or tearing of the skin or dislocation of the upper extremities. Now we're going to talk about carpal tunnel syndrome. The medium nerve compression is the wrist carpal tunnel. This occurs with swelling within that tunnel. Finger, hand, and arm pain and numbness are present, and this is usually worse at night. Relieves symptoms and inflammation. You rest the wrist. You can provide a cock-up splint, anti-inflammatories, and then there can be surgical interventions, which is a carpal tunnel release. The best way is to teach prevention. Okay. Fractures. This is a break in the bone. Causes are trauma. Okay, so a physical injury that happens to the area which causes the bone to break, or pathological. It results from a disease process. This could be osteoporosis or cancers. An open fracture is where the skin is broken. It's a high risk for infection. Closed fractures, the skin does not break and the skin remains intact. These are the various types of fractures that we discussed in class, and various mechanisms of how you could retrieve this type of fracture. Okay. Signs and symptoms include pain, decreased range of motion, limited limb rotation, deformity or shortening of the limb, as well as swelling and bruising. Diagnosis of a fracture can be done by visual examination, but confirmation must be obtained by an X-ray or CT scan. Emergency treatment, splint it to prevent the fracture from moving around or causing any further damage, and then seek medical attention. Goals are for the realignment of the bone ends and immobilization. The picture on the right of the screen here is a traditional cast that was used for fractures. The picture kind of at the bottom, this is a new like 3D printed fiberglass cast where you don't have the same restrictions as far as like getting it wet. This here is a visualization of the healing process or healing phases of the fracture. There's formation at the fracture site, fibroblasts, then osteoblasts arrive to help kind of start the repair process. Fibrocartilage calculus forms, new bone begins to form, and then the bone remodeling continues until the bone is intact. Closed reduction requires a manual realignment, meaning pulling the bones back into place. Then it is secured initially by a splint. Once the swelling subsides, if it needs a further immobilization or more secured immobilization, then a cast could be applied. You can also do skin traction to help with relieving pain until surgical intervention could be started, or a splint could be put into place. Traction can occur either by the skin, so using bandages and wraps, or, skeletal traction where pins and rods are placed through the skin into the bone, and then the weights are connected that way. The important thing to remember with traction is that the weights must remain free floating. Okay, this is a picture of internal fixation and not skin traction. Okay. You can also do an open reduction with internal fixation, which is what the previous picture was. And then they also have external fixators. Okay. Again, this is like with the skeletal traction with the external fixator. It's pins and rods that are drilled into the bone through the skin, and then a device is erected on the outside of the body to provide immobilization. This type of surgical repair requires pin site care at least once a shift. Complications of fractures could include a non-union of the bone, neurovascular compromise, hemorrhage, infection, thrombolytic complications, or acute compartment syndrome. You could also develop a fat embolism. Compartment syndrome, this is where this is a common potential complication for fractures. It's where the different fascia that surround each compartment become compressed, and either the vascular or neurological part of the nervous system is compromised. This is a medical emergency and does require immediate intervention. This is how a cast is removed after usually 6 to 8 weeks of healing time. Okay, these are possible nursing diagnoses that you could utilize for a patient that has a fracture. Okay. It's important when you're applying a cast or assisting with cast application that you maintain the extremity in the position that you would like it to be until the cast is hardened. Okay. Nursing care could include cast care, traction care. You want to make sure pain is well controlled for your patient. You're doing regular neurovascular checks, and neurovascular checks include a circulatory, nervous sensation, and movement. Skin care, nutrition to help with healing. Okay, patient education. If they are provided with a traditional cast, they should be reminded to keep the cast clean and dry to the best of their ability, not to get it wet. Pin care should be done to prevent infection, and then they should increase their protein within their diet to help with healing. Okay, osteomyelitis, this is an infection of the bone. This is a very serious infection, which is very difficult to treat. The key is prevention. Some of the signs and symptoms that you could see for a patient that has osteomyelitis would be fever, redness, heat at the extremity, pain, and swelling. This person is going to potentially be on long-term antibiotic therapy. It may require incision and drainage of the site, and potentially, in some severe cases, amputation. Okay, this is just a visualization of osteomyelitis and how it progresses. Nursing care for osteomyelitis. There's a lot with medication teaching. These patients, particularly if they're on long-term antibiotic therapies, need to be told precautions to take so they can prevent the development of C. diff. Good hand hygiene, especially if they have dressings that need to be changed. Okay, and then how to maintain a sterile dressing change. Osteoporosis. This is a condition that results in low bone mass as bone density is lost. People with osteoporosis are very prone to fractures. Fractures occur most commonly in the spine, wrist, and hips, but all bones could be affected. The patient can have an imbalance in their mobility when the remodeling process is going on. Approximately 57 million people suffer from osteoporosis, most of them over the age of 50, have some sort of fracture. 1 in 2 women suffer from osteoporosis, and 1 in 4 men. And it's expected by 2020, half of all Americans over the age of 50 will have osteoporosis or low bone density. Hip and vertebral fractures. These are common with osteoporosis, and these are very serious fractures in the elderly because it reduces their quality of life as well as increases their disability and increases their risk of death. For prevention, treatment is gained at prevention. You should try working on building your bone up through age 50, and you do this by getting adequate amounts of calcium and vitamin D, exercising regularly, especially in childhood, and avoiding alcohol and smoking. These are the risk factors that are associated with osteoporosis. Aging, being of Caucasian or Asian descent, being a small-boned or petite body build, being postmenopausal, having low testosterone or estrogen within men, family history of osteoporosis or fractures, or a history of fractures. Other risk factors can include low calcium intake, low vitamin D, excessive caffeine, or excessive caffeine, protein, or sodium intake, having a sedentary lifestyle, excessive alcohol use, and cigarette smoking. Okay. Other signs and symptoms that your patients may have osteoporosis include the Duewegger's hump, kyphosis, a decrease in their height, back pain, as well as fractures. Osteoporosis affects the body systems, functional effects, emotional effects, and socialization. Diagnostic tests, they will do a dual energy X-ray absorptiometry, serum calcium and serum calcium and vitamin D will be decreased, serum phosphorus will be increased, and your serum alkaline phosphate will be increased. Therapeutic interventions, you want to reduce the risk factors that would be considered modifiable. Encourage calcium and vitamin D supplements, as well as any other medications. These other medications could include anti-reabsorptive medications like your bisphosphonates, okay, or your calcitonin. You can also do monoclonal antibodies, selective estrogen receptor modulators, as well as estrogen therapy. Okay. Anabolic or bone-forming medications would include teriparatide. Nursing care would be aimed at pain relief and symptom management. education on how to increase dietary calcium and vitamin D, the importance of exercise or exercise modification, and then medication, and most importantly, fall prevention. And we have gout. This is a systemic connective tissue disorder where uric acid is built up. This causes urate crystals to be deposited within the joints and connective tissues and results in severe inflammation. Primary cause is an inherited problem with purine metabolism. Your secondary cause is often associated with other health issues. In an acute phase, signs and symptoms for gout would be red, hot, swollen, painful, inflamed joints, and this typically occurs in the great or big toe. Chronic gout, the urate deposits under the skin, and the person or patient could develop renal calculi or renal stones. Diagnostic tests would look at the serum uric acid levels, and you could also do a joint aspiration of the synovial fluid to check for uric acid crystals. Therapeutic interventions. During the acute phases, you would take medications like colchicine as well as NSAIDs. In chronic gout or gout prevention, you would include the febuxostat, allopurinol, or probenecide. Nursing care, education is a big thing here. Diet, they should avoid foods that are high in proteins. They should avoid aspirins, diuretics, or alcohol. And they should increase their fluid intake to avoid the development of renal stones or renal calculi. Osteoarthritis. This is a degenerative joint disease. It's very common among the elderly. The articular cartilage or joint ends become deteriorated. The joint space is narrow. Bone spurs develop and the joint becomes inflamed. Joint deformities, pain, and immobility. And this typically occurs in the weight-bearing joints. Here's a visualization. It's showing your hip, which is considered one of your weight-bearing joints, and the changes that occur because of osteoarthritis. The exact cause is unknown, but there are some risk factors that are often associated with the disease. These can be aging, obesity, as well as excessive wear and tear on the synovial joints. Signs and symptoms include joint pain, which intensifies after physical activity, feeling stiff, the Herberdens and Bouchard's nodes, which are bony nodes on the finger joints. Diagnostic tests that are performed to test for osteoarthritis would be X-rays, CT scan, MRI, or a synovial fluid analysis. Therapeutic interventions, there's no cure for osteoarthritis. The plan is to prevent disease progression and symptom management. This can be done through medications like NSAIDs to help with inflammation, rest and exercise, heat or cold therapy, weight control. You could also do complementary therapies to help with pain management, as well as surgeries like a total joint replacement. These are some common nursing diagnoses that may be used for a patient who has osteoarthritis. Patient education would include how to protect the joints from further damage, as well as how to conserve your energy so they don't become worn out. Now we're going to talk about rheumatoid arthritis. This is a chronic, progressive, systemic inflammatory disease that destroys the synovial joints and other connective tissues. This includes major organs. This is a picture of some of the deterioration and bone destruction in the joint because of RA. RA, it starts out with synovitis. The synovium thickens and fluid can accumulate. Destructive pannus erodes the joint cartilage and destroys the bone. The pannus converts to bony tissue. It results in joint deformity, and other connective tissues are affected. Okay. Oral pathogens are suspected to be the cause. There's also a genetic predisposition, meaning if you have a family member that suffers from rheumatoid arthritis or RA, then you are more likely to suffer from it. There's also an environmental factor, and this is considered an autoimmune disease because there's an autoimmune response, meaning antibodies, particularly the rheumatoid factor, results in localized and systemic inflammation. Signs and symptoms can vary by individual, but the thing about RA is that there are periods of remission and periods of exacerbation. And as the disease progresses, there are fewer periods of remission and more frequent and longer periods of exacerbation. Early signs and symptoms with RA, it's bilateral symmetrical joint inflammation. It's reddened, warm, swollen, stiff, and painful. The stiffness occurs after resting. Activity will decrease pain and stiffness in these patients, and they could have a low-grade fever, weakness, fatigue, or anorexia. Later symptoms include joint deformities as well as secondary osteoporosis. This is just a visualization of the joint anomalies of rheumatoid arthritis, and the big thing is your swan neck fingers, and this is kind of a picture shows you a little bit of the swan neck. Diagnosis for RA, you'd look at serum levels of the rheumatoid factor, RBCs, C4 complement would be decreased. Look at the ESR rate, then anti-nuclear antibodies, as well as the C-reactive protein. Medications, antibiotics for any infections. You want to do disease-modifying anti-rheumatic drugs, okay? Methotrexate. Gold therapy is something that was used traditionally to treat RA, but it is no longer being used. Also prednisone and NSAIDs. Other alternative interventions could be heat and cold therapy, balancing rest and activity, and then surgeries for total joint replacement. These are nursing diagnoses that could be used for the patients that suffer from rheumatoid arthritis. Education for these patients would be the disease process for RA and how it will progress, medication management, how to balance rest and exercise, have the patient meet with a vocational counselor because RA eventually does lead to total disability. And then are there any community resources available to assist the patient? This was an activity that we did in class, so just refer to that. Now we're going to talk about total joint replacements. We'll start out by doing a total hip replacement. This includes an acetabular cup that is inserted into the pelvic acetabellum. And then there is also a femoral component inserted into the femur. Both of these aspects would be considered a total hip replacement. You could have the possibility of a partial hip replacement, and it would only include one of these portions. Preoperative care. Education should be provided to the patient prior to having surgery. Some patients may choose to do what's called an autologous blood donation, meaning approximately 6 to 8 months before the surgical procedure, they would periodically go to the blood bank to provide samples of their own blood in case they were to need any blood transfusion after surgery. Postoperative care would be to prevent any complications. Common complications of hip replacements would be hip dislocation, skin breakdown, and pain. Okay, this is a picture of an abductor pillow. This prevents the specific movements that a patient should not be doing while after they've had their joint replacement. Okay, they should avoid having more than a 90-degree angle when they're sitting or getting up. Okay, postoperatively, you'd want to prevent infection, so the patient might receive prophylactic antibiotics before Before or during their surgery process, you'd educate the patient to do turn, cough, and deep breathing before surgery, and then reinforce that teaching after surgery, and then monitor the incision and doing dressing changes. Monitor the incision for bleeding. If there is a drain present, then you are monitoring the output of that drain, and then you're doing your neurovascular checks to prevent any neurovascular compromise. Ambulation will help to prevent complications. So a lot of times these patients will be working with physical therapy, and a lot of times they will use a walker and or crutches to help with prevent any falls. Thrombolytic prevention includes the use of compression devices, or SCDs. Those are the devices that wrap around the legs and inflate with air periodically to help blood flow throughout the lower extremities to prevent the development of a blood clot. The patient can also do exercises with their legs while they're laying in bed, and they are typically put on anticoagulant therapy like Lovenox or heparin. These patients, after a total hip replacement, because they have restrictions on their movements, they may require the use of assisted devices, a raised toilet seat, and they may even participate in acute rehabilitation. Total knee replacement, this has a femoral component, tibial component, and a patellar button. With total knee replacements, there is no concern for dislocation, but the postoperative care is a lot similar to that of a hip replacement. Amputations, this is the removal of a body part. With an amputation, it can either be surgical, and this surgical amputation could occur because of bone ischemia, ischemia from peripheral vascular disease, or bone tumor, frostbite, congenital problems, or infections like osteomyelitis. You could also have a traumatic amputation, which is typically the result of some type of accident outside of a healthcare facility that results in the loss of a limb. Replantation, you should wrap the severed body part in a clean, slightly moist cloth. It should be placed in a sealed bag and placed on top of ice, and then transported to the hospital with the patient. The success of the replantation depends on how the part was severed, how long it's been away from a blood and oxygen supply, and that sort of thing. Levels of amputations, how they're described. For the lower extremity, it's either below the knee or above the knee, and then on the upper extremities, it's either below the elbow or above the elbow. And these are the appropriate abbreviations that you'll see used for each. Nursing care, preoperative nursing diagnoses could be deficient knowledge or disturbed body image. You want to make sure that you're offering a lot of support to your patients, especially if it was an amputation that occurred because of a traumatic accident. Postoperative care, you want to monitor for bleeding, infection, and make sure you have pain control. It is not uncommon for patients to experience what's called phantom pain, meaning they still have pain sensations on the body part that is missing. They'll have some adjustments to their mobility and ambulation. Postoperatively, they'll also have to adjust or make changes to their lifestyle and potentially utilize a prosthetic. This is how you would do a bandage for an above-the-knee amputation. These are some review questions that we discussed in class. Thank you for listening to this recording. If you have any questions, please follow up with your primary instructor.